and I'm YAMANE from Japan. Today I'd like to talk about flanged IOL fixation, parts and pitfalls. This is a video of my surgery. I first make PI before pupil dilation, then remove the dislocated IOL and make 2 sclerotomies with 30 gauge thin-wall needles. Then insert a new IOL, and the leading haptic is inserted into the first needle, and the trailing haptic is inserted into the second needle. In this time, I just put the needle on the sclera, just release the first needle. Then the haptics are externalized with the needles, and I usually trim the haptic to make good centration and control tilt. Then make flange, and the flange are pushed back and fixed into the scleral tunnel. This surgery is very simple, but there are many tips and pitfalls. And today I'd like to show you how to master this technique. The first, bending the needles. The needle should be bended about 45 degrees with bevel up. This is 30 gauge thin-wall needle. If you can't get 30 gauge thin-wall needle, you can use 27 gauge needle. And you should practice to insert the haptic into the needle before the first case. The grasping point is very important. If you grasp the haptic and very near from the tip, you can't insert the haptic into the needle. And if it's too far, difficult to control, so you should grasp the haptic about 3 millimeters from the tip. And you should attention about the direction of the needle hole. If the needle hole faces to inward, in this situation, it's impossible to insert the haptic into the needle, so you should turn the needle. And if the needle hole faces upward or outward, you can insert the tip of the haptic. So you should practice to insert and find which direction is best to insert the haptic into the needle. And you can change the direction of the haptic too. No, sorry. Okay. Sorry, the movement of the video is not so good now. So you should pay attention to the direction of the needle hole and the haptic. It's easy to insert the haptic into the needle on the table, but inside the eye, the space is limited. It's more difficult, so you should practice before the first case. And you must use both of the right and left hand. And next, you should practice using porcine eye or model eye. The positional relationship of the wounds is very important. If the main wound for IOL insertion and the left square toenail is very separated, you can't align the needle and the haptic, so difficult to insert. So the main wound and the left square toenail should be separated about 70 degrees so that you can easy to insert the haptic into the needle. So next step is making wounds. I usually make one side port, and the square toenail made 2 millimeters from the corneal limbus with angled incision. As you can see, the length of the corneal square toenail is about 2 millimeters, and I don't change the direction before penetration, just oblique incision. It's difficult to control the insertion angle, and the insertion angle is very important to control the tilt and scintillation, so I made a special instrument to control the insertion angle of the needle. This instrument has ring-shaped body with 2 wings, and the wings has grooves to pass the needle, and the needle intended to go 10 degrees downward and 20 degrees inward. And the clothes can hold the eyeball during inserting the needles. This is how to use the needle stabilizer. Just put the needle stabilizer on the eyeball and push the needle along the groove of the wings. So next step is insertion of the IOL. It should be inserted on the eyelid and grasp 3 millimeters from the tip and align the needle and haptic, then insert it. And it's safe to release the first needle in this situation and do same thing, grasp 3 millimeters from the tip, then insert to the second needle. Some doctors use single needle technique, just externalize the leading haptic, then insert the second haptic, drilling haptic into the needle. But it's possible, but sometimes difficult if the cornea is small or the pupil is small, and the lens go downward. So I recommend you to use double needle technique, 2 needles. And step 6 is haptic externalization. It's not so difficult, just pulling out the needles. But you should be careful not to externalize only one side. It has a potential risk of strip down of the another side. So I recommend you to externalize both sides together and keep the optic at the center. Then step 7 is making flange. Just heat with cautery. Not so difficult, but some tips. You should dry up the haptic before making flange. If the flange is covered with OVD, viscoelastic materials, you can't make flange because you can't heat the haptic enough. So you should clean up the haptic before making flange. And do not touch the haptic with cautery, it will adhere. And some material, PMMA material, will disappear with heating, so you should try to make flange before the first case. So the final step is flange fixation. Just push back the flange into the square tunnel. But sometimes it will go out after surgery, so you should completely push back into the sclera. If the flange is too large to pushing back, you should enlarge the corneal tunnel, entry site of the scleral tunnel. Then you can insert the haptic completely inside the sclera. So for mastering flange IOL fixation technique, please try this 8-step method. And please remember, it's very important to understand how to insert the haptic into the needle. Thank you for your attention.
Thank you, Dr. Yamane, for very educational way of presenting your technique. And I'm sure after this, many of us will take it home and practice. Thank you so much.
Thank you.
Any questions? We'll take one. Yeah, please. Please use the mic. And some of you who are standing behind, there are some chairs right in front. You all can come and sit here.
How many cases that one of the flange or both the flanges come out of the sclera and hanging into the vitreous?
Case number?
Because it's a very fine, small thing. There is a possibility that it can come out of it or no?
Sorry.
His question is, what has been so far the incidence of the flange going off and the needle, the lens hanging into the vitreous?
Into the needle. I have no case to go inside. I have 2 cases which go outside, but that is a cause I didn't push the flange completely inside the sclera.
Do you do entire vitrectomy also by open sky method before inserting the lens? Entire vitrectomy.
I usually do partial vitrectomy, but sometimes do only anterior vitrectomy if the resident occurs a post capsule rupture. Then convert to the flange fixation. I just do anterior vitrectomy, but normally I do partial vitrectomy.
Is there any chance for IOL tilting?
Yes, in my personal data, the main average tilt is 4 or 5 degrees, under 5 degrees, 3 or 4 degrees. But for beginners, the tilt is larger than me, so I recommend you to use a special instrument. The insertion angle of the needle is very important to control the tilt.
Thank you, Dr. Yamane. Please come.
Thank
We
you.
start with the instruction course now, and because